The quick 1-minute summary on an article that looked at isolated isometric core exercises compared to integrated dynamic exercises and their effect on muscle activation of the core. And what they found overall is that the isolated isometric core exercises activated the core muscles more so than the integrated dynamic exercise, which was a lunge. But is it as simple as that? Stay tuned and let's dive into some of the details. So the goal of the study by Saderbakken was to look at the muscle activation of various core muscles during both the isolated isometric core exercises compared to the integrated dynamic exercise. And for the isolated integrated exercises, what those were a front plank to look at the abdominals, a back extension for the paraspinals on the back, and then also a side plank, which was for the lateral core muscles, so the obliques. And then for the dynamic integrated exercise, that was a lunge. And the lunge had a couple of different various changes that they did to help bias the lunge. So they did it on a stable surface. They also did it on an unstable surface. So when they stepped, they would step onto an Eric's pad. And then they also had a category where they increased the resistance to bias some of the different muscle groups of the core. For example, they had all of them actually used an exercise band, and what they would do is they would have the exercise band anchored around the torso, and then, for example, they would do a reverse lunge to bias the paraspinal muscles on the back, or they would anchor the band behind them and then do a front lunge, where then they would be biasing the anterior core muscles, so the rectus abdominis, and then same thing for the lateral core muscles, they would anchor it to the side, and then that way the band would try to pull them over to the side. For peak EMG levels, they found that the isolated core exercises produce a significantly greater activation level for both the paraspinal muscles, so the erector spinae, as well as the rectus abdominis. When they looked at the oblique muscles, so for the lateral stability, they found that the only significant difference was between the isolated side plank and a stable lunge. So the difference between the unstable lunge as well as the resisted lunge were not significantly different from the side bridge. Interestingly, when they looked at the peak EMG levels between the different lunge variations, they only found that the significant difference was for the erector spinae. All the other conditions for the lunges were not significantly different from each other. And then when they looked at the mean EMG levels, they found that the isolated core exercises were better than all of the lunge variations. And then when they looked at the lunge variations, there was no significant difference between any of the different conditions. And when looking at these results, they're not really that surprising when we think about it. And the reason why is because if we're doing a targeted exercise to isolate a specific muscle region, then we'd expect the EMG levels to be higher in those muscles when performing that exercise. So the fact that we're doing isolated core exercises, specifically trying to target either the abdominal muscles with a front plank, or the erector spinae muscles with a back extension exercise, or the oblique muscles with a side plank, that makes sense that we'd have higher activation levels than a more integrated exercise such as a lunge. But when we look at the clinical impact of this kind of information, I think that's when it really gets interesting, because if we look at the information here, yes, the isolated core exercises produce statistically significant differences compared to the lunges. However, is that information actually clinically relevant? For example, for the front plank, for activation of the abdominal muscles, let's say we get about 50% of maximal voluntary contraction, whereas with the lunge we get 30 or 20%. Is that difference actually relevant in any manner? I don't know if it actually is, especially when we put this information into a bigger context and saying, for low back pain specifically, and granted the information in this study wasn't on those with low back pain, but if we look at it in that context, no core exercise program has really been shown to be or produce better outcomes than general exercise. There was just a study that looked at walking versus a spinal stabilization exercise and found that they're about the same in terms of outcomes. So even though we're getting higher activation levels with these isolated core exercises, for pain and function, they don't really seem to make that much difference. So while yes, these exercises might get us stronger in those areas, for their relationship with injury or pain, that relationship isn't very strong. And so while this information of EMG levels is interesting, it's hard to really implement this into clinical practice because I don't really think it changes that much, because when we're looking at rehab programs, especially for those with low back pain, the goal isn't necessarily just to have them be really, really good at planks, being able to hold for 5 minutes or 10 minutes, or have a 45-pound plate on their back. Yeah, like they can do that if they want to, but that doesn't necessarily translate well to function. Instead, we kind of use some of these lower load exercises to help kind of just build into more integrated exercises such as lunges and squats and all that kind of stuff. So I just have a hard time really kind of integrating these EMG studies into or making them more clinically relevant. Although I'd be interested to hear how you actually implement this kind of information into your treatments, whether that's creating a training program or a rehab program. While this information shows that there's statistical difference in muscle activation strategies with these various exercises, especially when comparing isolated core exercises to dynamic exercises, what does that actually mean clinically for you? Go ahead and let me know in the comments below.